I would like to introduce our first speaker, who is Madam Shavina Arunasalam. For those who have known her, Madam Shavina graduated from University of South Australia in 2006. She also had the opportunity to work in Australia as an intern pharmacist before returning home in 2007. Currently, Madam Shavina is practicing in Hospital Tuanku Ampuan Rahimah Klang, one of a busy hospital in Klang, as a surgical ward pharmacist, and she is also actively involved in the MTech program for warfarin, methadone, and pain management, of course. So, Madam Shavina, we look forward to your talk. The 50 minutes is currently yours. Please welcome Madam Shavina.
Thank you, Dr. Nur Fasihan.
Right.
Thank you, Dr. Madhu and the organizing committee for giving me this opportunity to share on the pharmacy's role in pain-free program. Next slide, please. So this quote by Dr. Samuel in the early 18th century says that those who do not feel pain seldom think that it is itself. So early in those days itself, he has recognized that pain is something that is often not prioritized by our healthcare workers. Whenever a patient comes in for any disease, our focus is on the disease, the pathophysiology, the treatment plan, prognosis, and so on. We forget the most basic symptom that is pain. The patient is discomfort, and that pain needs to be addressed because the patient needs to be pain-free. Next, please. So the reason why, since pain hasn't been recognized for the longest time, so we decided that pain is an important factor that needs to be recognized, and they come up with pain being the fifth vital sign internationally. However, in 2008, Malaysia decided to adopt pain as a fifth vital sign, and we have been establishing pain-free hospital in stages from 2008 until now in various government hospitals, and we've expanded to university hospitals and also some private hospitals. So what is pain undertreated? All types of pain in all parts of the world are inadequately treated, be it acute, chronic, cancer, or non-cancer pain. With all the advancement in science and medicine, there are various treatment modalities available for cancer. What more for cancer pain? And it is found that up to 90% of cancer pains can be relieved of their pain, yet fewer than 50% receive adequate treatment. A survey by the National Acute Pain Service Unit in Malaysia showed that 76% of post-laparotomy patients suffer moderate to severe pain in the first 24 hours. So, moderate to severe pain here is defined as patients who tell you that their pain score is 4 and more. So, all the patients in medical wards or patients who have surgery. So, just to add on, I used to be the surgical pharmacist, but now I'm a medical ward pharmacist. So, in the surgical ward, definitely pain management is one of the top priorities in our treatment plan. But when I moved on to the medical ward, I realized that there was such a change, or rather such a difference in treatment plan. Pain is not often the top in the list. So, in the medical ward, we have patients who come in with MI, patients who have uncontrolled diabetes, hypertension. So, our treatment goal always is to bring down the pressure, bring down the sugar levels, get that all under control, but we forget that the patient is in pain. We don't think that the pain management is important. That's one. The other thing is, another symptom that our clinicians have, opioid phobia. I'll talk about that later on. Personally, I remember having a patient in the medical ward who was having bone pain due to cancer. And the patient was crying every time he came in for workup. And it took me almost 2 to 3 days to convince and beg my clinician to start the patient on opioid. She was already on a partial opioid, but she wasn't responding. And the doctor was so reluctant because he was so afraid to start the patient with that. We'll talk about opioid phobia later on. Next slide, please. Okay, so why is pain undertreated? Going back to what I mentioned earlier, organizational barriers, low visibility. Clinician barriers is low priority, not thought about as an important factor. Poor knowledge and misconception. Poor knowledge, not knowing the difference between acute pain, chronic pain, cancer pain, chronic non-cancer pain, and misconception. Misconception here is referring to opioid phobia again, worrying about things like addiction, side effects, maybe about sedation, respiratory depression, and so on. The patient and public barriers, so we share some of the common concepts between the physician barrier and patient as well. Patients also worry about addiction and the adverse effects of anesthesia. They believe that a good patient does not complain of pain or disturb meetings of doctors for pain relief. So some of the cancer pain patients, they worry about not wanting to divert the doctors from the chemotherapy. If they talk about the pain, they worry that the doctor might divert from the treatment plan for the cancer, and the cancer might get worse. Another thing in some of the diabetes patients that I see is that they think if the pain is something that you need to deal with, not just diabetes patients, cancer patients, but also some of my HD patients. They think that pain is something that you just need to live with, and they shouldn't necessarily need to complain about it. So they decide not to talk about that pain. Next, please. Next, please. Okay, so as you know, pharmacists, next slide, please. Okay, as you know, pharmacists also clinical decision making in hospitals and clinical care plans and so on. But a study that was done in California in 2006-2007 showed that pain management pharmacists discharge facilitation at stage cost approximately $97,000 for a 1 year period. So pharmacists have an essential role to also save costs, to be involved in ensuring cost effectiveness and safety of their pain medication. The Pharmaceutical Services Program under the Ministry of Health had showed support for the pain-free hospital initiatives by providing individualized pain medication therapy management to patients. So under the Pharmaceutical Services Program, we have something called the Pain Task Force, comprising of pain pharmacies from all over the country. So we've come up with various guidelines in terms of pain medication therapy management. We discuss issues related to establishment of pain-free hospitals and so on and so forth. Next slide, please. Let's look at the roles of pharmacists in pain management. We've divided them nicely into technical and clinical roles, and I'll talk about these in my next few slides. As a general role in pain management, we are involved in planning and implementing continued professional development strategies to improve current and future performances. So we organize training sessions and public health talks about pain management in shopping malls and so on to improve effectiveness and healthcare system in public health as well. Next slide, please. So let's look at the technical aspect of things. Next slide, please. So, firstly, to obtain, store, and secure. So, if your hospital is established as a pain-free hospital, this is actually an accreditation that's given to you, and there's 10 criteria involved in establishing your hospital as a pain-free hospital. So, usually, a pain-free hospital consists of a pain specialist. So, if you have a pain specialist in the hospital, you will have an extensive list of anesthesia involved that you may have access to. So it's important to prepare a list of essential medications needed for the pain-free hospital, including your control items, psychotropic substances, and non-formulary items. This is very important, especially now that we have the whole cluster concept. You have your main hospital and the cluster hospital. So usually the main hospital will be the one that has the pain specialist. So you, with the cluster concept, where we share resources, meaning we share our resources. In terms of medication, off and on, you need to share this pain medication with your cluster partners. It's not extensively done yet, but occasionally we need to do that. So ensure that we do share it, but always a check and pound at the end of the day. So it's important to coordinate with relevant pharmacies, sub-store pharmacies, outpatient pharmacies, logistics, and understand usage, quota, So slow-moving items, short expiry items, and import permit items. So for pain management, currently the drug that needs an import permit is Multidisciplinary. It's not manufactured in Malaysia anymore. So this import permit needs to be renewed annually. Apart from the sub-store pharmacy and outpatient pharmacies, the other thing I forgot to add is that you need to identify your paying pharmacies, because the paying pharmacies can help appetite getting drugs or sending out short drugs. We do a lot of exchanges within our counterparts in various parts of the country to ensure that the drugs are optimized and there's no wastage. And if you need any drugs, you're running out of any drugs, you can get them from the counterparts. Hello? Alright. So to ensure sufficient stock availability, establish contingency plans during shortages of medicine for purchase in emergency. So a few years ago, one of the problems that we had was the nationwide shortage of morphine syrup. So as you know, in the government sector, morphine syrup is done from scratch by the hospitals itself. So we're having a nationwide shortage. So some of the contingency plans that we were thinking about, we were thinking about getting commercially available morphine syrup. Alternatives to that, if that was not available, we're going to think of another short-acting opioid, which was oxycodone. It's a very expensive alternative, but these are the alternatives that we must be prepared for and to prevent shortage. Fortunately, by the time we decided to purchase the commercially available morphine syrup, the shortage was resolved and there was no break in supply to the patients. To ensure proper storage conditions of your controlled substances and fridge items, the controlled substances need to be stored appropriately and make sure there's a recording of it wherever it is kept. Especially if it's in the ambulance, because ambulance sometimes they forget about recording, so that's very important. Next slide, please. Okay, so these are some of the common medications. Injection paracetamol, your usual NSAIDs, which I'm not going to go on about. As you know, NSAIDs need to be short-term only. Your opioids, what weak opioids do you have in the hospital? Apart from tramadol, what are the next options? And strong opioids, we have all these mentioned here, and your methadone syrup. So if you notice next to the methadone syrup, there's an asterisk there. The reason why we put an asterisk next to methadone syrup is because in the blue book, methadone syrup is indicated for heroin replacement, and it is not for pain management. So if you're going to use it for pain management, it will be an off-label use. I'll talk about off-label later on. Next slide please. So neuropathic drugs, we use tricyclic antidepressants such as nortriptyline, amitriptyline, your anticonvulsants, gabapentin, pregabalin, your SNRI, PCA, patient control analgesia, and epidural, topical application, and some combination items which is not available in the government setting, only at the community pharmacies, which are your combination items. Next, please. So to distribute, prepare, and dispense. So distribution is fairly reasonable, assures reliable quantitative methods to ensure that the medication is distributed appropriately from the store pharmacy to ward supply, from ward supply to the ward, to from the discharge pharmacy back home. And in terms of preparation, ensure that it's conducted in the appropriate technique, especially in sterile environment, to ensure efficacy and safety of product. And this is usually done for patient control anesthesia IV admixture. And for extent preparation is done according to ensure that it's done according to the formulations by Ministry of Health extent formulary and proper references. For example, morphine syrup. So some settings, morphine syrup is done using the extent syrup, and in some settings, morphine syrup is done using chloroform water. Do you know the differences between those two formulations? Oh, sorry, you can't answer. Yeah, so the difference is basically with the extent preparation. A lot of patients like it because it's very sweet. There's a person that it doesn't taste as well. So now, and also with the extent preparation, it's the expiry date is for a longer period of time. So these are things that you should consider for preparation. Again, patient to patient basis. Not everybody likes sweet medication. So you see which formulation works for you or for the general population. Next, please. Dispensing practice should be practiced. So institutions that don't have a pain clinic may need to find a mechanism to differentiate pain management prescriptions from ordinary prescriptions. So when we talk about pain management prescriptions here, it refers to patients who have chronic pain. So it's been suggested that we have pain-free prescriptions on the prescription. So you'll know that these prescriptions will need special attention. Quantity of medication supply depending on the indication. So this is always a problem everywhere. We always minimize how much we give to the patient. In government hospitals, I think it's not a big problem. But when we have a training session and we have discussions with the clinic kesihatan counterparts, they always tell us that's one of the biggest problems, especially clinic kesihatan in district area, far remote areas, minimal budget. So they have to really allocate very minimal amount. Some tell me they even give 3 to 5 tablets of tramadol only for each patient. So this is definitely a concern for us, and something that we've been discussing at the pain task force as well. And we're hoping to we've had discussions with the stakeholders involved in the clinic kesihatan setting. Because in the near future we're going to establish pain-free concept to clinic kesihatan as well. So once we do that, there should be a reasonable access to pain medications. A reasonable amount should be given to patients for pain. So supply depending on indication, even in general hospitals, don't change with your pain medication. Look at the indication. If it's for something like soft tissue injury, you would expect the patient to just have an acute pain management, so you can give a fairly small amount of medication. But if you see the patient is there for post-op appendicitis, then you should know that the patient will be in pain for at least a week or so. So please be a bit more judicious. The patient is admitted for something like post-spinal instrumentation. You would expect the patient to be on some chronic spinal neuropathic pain. So please be more generous with these types of patients. Know your patient, know your indication. So please ensure that patients receive enough medication at the pharmacy. Next slide, please. So different psychotropic substances are usually used for pain for 7 and more, and we cannot run away from the fact that psychotropic substances have high risk of misuse and abuse. So we have to look at the US for this example. In 2015, I'm sure you've all heard of the opioid crisis, which is really big in the US. It's so big that they decided to de-recognize pain as a fifth vital sign and pointing fingers that was the reason of the misuse and abuse. And I think in 2018 they came up with a declaration for the opioid crisis, whereby they had a senators meeting and they decided to expand addiction services, to ensure there's no abuse of drugs, and ensure prescribing of medication are limited, and so on. Thankfully, we are still very far from that risk of misuse and abuse, but it's always important to be aware and to have it at the back of our minds when it comes to psychotropic substances. So for procurement, storage, dispensing of these groups of medication, we have the Dangerous Drug Act 1952 and your Poisons Regulations 1989. But I suppose the Regulations 1989 is more supplemental because it really goes down to the details of the professions involved or allowed to prescribe psychotropic substances. Talks about what are the steps involved in prescribing medication when it comes to psychotropic substances. Talks about dispensing it. It talks about recording these medications, so on and so forth. Next slide, please. So medications requiring special approval. So these medications are medications which are listed in the Ministry of Health formulary, also known as the Blue Book. So if they are not registered in Malaysia, or if they are registered in Malaysia but they have an off-label indication such as the methadone that I mentioned earlier, you will need special approval. Or if the medication is not in your Blue Book, such as Ultraset and the medications below, then you will need special approval from the Director General of Health or Senior Director of the Pharmaceutical Services Program Approval. So since our DG of Health currently is very busy with COVID crisis, so I'm sure our Senior Director of Pharmaceutical Services will be helping out with these approvals. So in terms of global medication, another concern, one of the things that we discussed at the same task force is limitation in prescribing this drug because of the indications mentioned. So we will be thinking about changing some of the indications and changing the professions involved and allowed to prescribe some of the strong opioids to make it easier for pain-free hospitals to have better pain management. Next slide, please. So in terms of medication that is off-label, another form that you need to fill up is your consent form, actually for the patients and caregivers. I'm not sure whether this is widely practiced. In theory, it's there. It's available on the pharmacy.gov.my website. For every off-label use, you're supposed to get a consent. Practically, I'm not sure whether it's been done, but in theory, it's there, it's available, and it should be taken into consideration. Next, please. Okay, let's look at the clinical aspect of the School of Pharmacy. Next slide, please. So it is a specialized pharmacy service provided by a trained pharmacist, especially in Ministry of Health facilities involved in the, they say, as a fifth vital sign. Next slide, please. So the objective of the service is to optimize pain therapy, either to reduce or control the pain, to minimize adverse events and medication error by reviewing the past and current medication, to counsel patients on the appropriate use of pain medication and to increase their understanding, and to collaborate and to provide information to healthcare providers on their pain medication. Next, please. Okay, so this is a general overview of the pain medication therapy management services available in the hospital. In the ambulatory setting, we have your pain MPN clinic, we have the pre-anesthetic clinic, and the general medication counseling. In the inpatient setting, we have your acute pain services or multidisciplinary pain team round and the general pain counseling. Next, please. To elaborate further on the clinical aspect of the services that we provide both in the ambulatory and inpatient setting is to provide effective pain medication therapy management. Firstly, it's important to assess the patient's health status and medication history. Know the patient's medical illness. Know whether the patient has cancer, whether the patient is a dialysis patient, whether the patient has COPD, asthma. Conduct thorough medication history assessment. This is very important for us as pharmacists. Ensure medication reconsideration where appropriate. Just to share about the importance of taking medication history, a few years ago I had a patient who came in for stroke, and unfortunately she was aphasic, unable to speak due to the stroke. And in the medical history, it was stated that the patient had a degenerative spine disease as well. So as I was doing the medication history with her, for every question that I asked her, she was replying to me through typing out on her phone because she was unable to speak. So then I showed me the prescription, and in the prescription it shows that she was on 600 milligrams in the morning, 600 milligrams in the afternoon, and 900 milligrams at night, and she was on an antidepressant for depression. So when you look at the prescription, we can tell that the patient has been in some sort of uncontrolled pain, which is why the doctor has been trying to tailor the dose to best suit the patient. Whereas when she was in the ward, when she was admitted for a stroke, if you looked at her, she looked unhappy, there was dimness on her face, and naturally everyone assumed that it's just because of the stroke. But once I identified that the patient was on this dose of gabapentin and we got the doctor to change it, over the next 2 or 3 days, there was such a difference in her face. So much of relief in her face, although she was unable to speak, but you can tell that the pain was the one that was the major problem for her, despite the fact that she was admitted for stroke. And she was actually able to smile a little bit more on the third day. So these sorts of things make such a difference to patients, the importance of medication history assessment. Another thing, if you know the patient, a lot of times patients think that pain medication is not something to be mentioned when you take a medication history. So if the patient says that I've got breast cancer stage 4, automatically at the back of the mind, you should know that this patient should be on some sort of pain medication. So if they don't tell it, you ask further, aren't you on something for pain? Are you not in pain? Then they might say, oh yeah, I'm on some painkiller, but I just take it when needed only. I didn't think it was important to mention. So these things are very important. So you need to know what the patient is, what medical illness is as well. Next slide, please. To manage patients' medication therapy. But it's been told that I'm not loud enough. I'm trying to see what else I can do to increase the volume. Just give me a moment, please. Yes, I just increased the volume a little bit. I hope I'm sounding better now. Is it okay? Is it better? Is it louder?
Yes, you sound a bit more louder than just now. Maybe there was a distraction at the background that makes your voice even more softer.
Okay, so now better, yeah? I'll continue. All right. To manage patients' medication therapy. So collect patient-specific information, assess medication therapy, and identify medication-related problems. Specific information that's related to most often is what's the renal function, what's the liver function, what are the symptoms that bother the patient. Assess appropriateness of each medication, benefit versus dosing regimen, indications, and so on. So always know that two patients with the same medical condition does not mean that they need the same analgesia. It will be different from patient to patient. Suggest evidence-based, individualized treatment. To monitor patients' progress and outcome, evaluate patients' responses, including safety and efficacy. So how do we evaluate the patient's response? How do we know that the medication is working for them? One easy way that is easy to manage is your pain score. Pain score is definitely something that we widely use, your VAS scoring. But other things to consider are simple things like activity of daily living. The patient says because they is able to sit down and to get up. Now they say that they are able to move around and get their own drink and make a cup of coffee. That is huge progress. Another thing about pain score is pain score of 0 is not something that is achievable for all patients. So set reasonable goals. So if the patient's pain score before this was 7, in a month's time, we hope that the pain score will come down to either 6 or 5. For you, it looks like a very small number, but 6 or 5 is a big number for patients with chronic pain. Monitor and assess patients' adherence. So this is a little bit tricky. For chronic pain, yes, we want adherence to be there. But over time, once sometimes patients are not just on analgesia, they're also on physiotherapy and so on, and they might benefit from physiotherapy so much that their pain is well controlled. Over time, they might consider cutting down their pain medications to PRN basis. So this is again case-to-case basis. Detect symptoms that may be due to adverse drug reaction. So always differentiate for cancer pain especially. Always want to differentiate whether it is the disease progression or the side effect of the drug. Report any area in medication errors detected. Next slide, please. To provide information about medicines and other health-related issues, to ensure sufficient health, disease, and medicine-specific information is given to the patient. So if the patient especially is on neuropathic pain drug, for example, they are on tricyclic antidepressants, tell them that this is also given for depression, rekomendasi untuk masuk kita bagi ni untuk sakit saraf. The information that we give will empower the patient. Patients who are empowered are more likely to be adhering to the medication and to be involved in the treatment plan and to have better response. Provide consultation and suggestions to address identified medication problems to other healthcare professionals. Provide updates on the patient's progress and recommended follow-up care. Provide education and training to other healthcare professionals, so moving out normal CMO, CPs, and so on a regular basis. Always make sure you communicate information about the patient with the clinician that is treating the patient as well. Next slide, please. Okay, moving on to pain MTM services in the ambulatory setting. So we're looking at the pain MTM clinic, pain medication therapy management clinic, also known as MTEC. Next slide, please. So the scope of the service is patient is included in the clinic, are referred by the pain specialist if it's a hospital, and if it's a clinic kesihatan, family medicine specialist, or selected pharmacist at the clinic. So usually we will operate as a pain clinic area on the clinic day, but it's not necessary to be in that area. For in Klang GH, there's no place in the pain clinic, so we see patients in the outpatient clinic. We capture them on the clinic days and we provide counseling to them at the outpatient pharmacy. So the manpower required, that there should be at least one trained pharmacist on duty during your clinic operating hours. Next slide, please. So the criteria for the clinician to come to select patients in the pain medication therapy management is patients who are newly started on analgesic and adjuvant, patients with therapeutic goals are not achieved with the current pain medication regimen, and patients on chronic pain requiring long-term pain medication and regular monitoring. Whereas patients who are referred to the pharmacist at the pain MTM clinic should include specific criteria in terms of change in their pain medication regime, if they're experiencing side effects or complications due to their pain medication, if they are on strong opioid, and if they have full understanding of their pain medication regimen. Next slide, please. So this is a general guide. This is a general guide for education and counseling checklist for patients who come into the pain medication therapy management clinic at the first visit. So at the first visit, we look at their treatment goals. What are the reasonable pain scores that you want to achieve? What are the other activity of daily living that you want to achieve? Or if you have plans of going back to work, so on and so forth. And then we look at pain score or cost, the name of the medication, dose, frequency, administration, side effects, storage, precaution, contraindication, and what is to be done when you use the dose when pain is not removed. Next slide, please. For subsequent visits, we revise the treatment goals again, and then we look into specific medication counseling, and if the patient has any concern in terms of side effects and so on, evaluating the pain score versus the medication, whether it's working for the patient or we need to switch the medication. We need to monitor signs of addiction, misuse, and tolerance of drugs. Next slide. So the general workflow is where the patient will be registered, the initial assessment by the clinician, and then the clinician will decide if the patient needs to be referred to the pharmacist or to other healthcare professionals. Now, it's important to remember that in pain management, it is not just pharmacological involved. There are lots of non-pharmacological modalities involved in pain management as well. It is a holistic approach. We've got physiotherapy, we've got your occupational therapy, as traditional occupational medicine also play a growing role in pain management. So then the patient is referred to pharmacist and do the initial selection, assessment, patient selection based on the criteria I mentioned earlier, your underlying comorbid, the medication history, pain history, the location of the pain, so this is the form of the and if there's any intervention, then you communicate the intervention to your clinician, and then you provide the necessary counseling and provide the next appointment date and of course documentation. Next slide, please. So subsequent visit will be about the same, and you follow the checklist that I mentioned earlier. Next slide, please. So at the pain MTM clinic, the things that are involved, medication and education counseling, And then it's important to know about round-the-clock medication versus when necessary medication. In terms of your pharmaceutical review, identify, assess, and also communicate with your physician. Pharmacy recommendation will be on the intent, the desired outcome, which will be discussed with your clinician, drug-related problem, availability and policy of medicine, and to collaborate with other healthcare professionals. Any interventions that you should discuss with the clinician. Discharge criteria, this is the criteria that we've set, but we've not discussed any patient. If anything, patients should have their pain well controlled or probably have their pain under control and they need taking medication, they themselves will stop coming to the clinic. So we've not really discharged any patient at this point. Next slide. So next ambulatory pain NTM service is at the Pre-Anaesthetic Clinic. The Pre-Anaesthetic Clinic is where patients go before they go for op. They will be assessed by the anaesthetic doctor whether they are fit for surgery. They will be advised on what medication should be stopped. They will be advised on what kind of pain to expect, what kind of pain management will be given to them, and so on and so forth. So the pharmacist here will perform the duty of taking the medication history, a medication review, counseling and education about the use of medication prior to surgery, and usually will be seated together with the anaesthetic doctor at the anaesthetic clinic. But again, depends on the study. It's not mandatory to be in the same place, whichever is practical for you. And there should be at least one trained pharmacist needed to provide the service at the Pre-Anaesthetic Clinic. Next slide, please. So we'll use your CP1 form for your medication taking. After the doctor has assessed, this pharmacist will assess the underlying comorbidity, take down your medication history, and then we have the pre-counseling form, pre-anesthetic counseling form. Next slide, please. So if you look at the counseling form, the pre-anesthetic counseling form, we have instructions here about what medication that needs to be withheld either on the day before surgery or 1 week before surgery, and the evening before procedure, what medication should not be taken, what kind of pain will they expect after surgery. So immediately after surgery, what kind of pain management will be given to them? What are the side effects to expect? Subsequently, when they are revisited after 24 hours, they might consider switching the patient to an oral anesthesia. So when you give all these sorts of information, it really reduces the patient's anxiety and stress because they know what to expect. They know they're not unknown. They know what's going to happen next. If they're not knowing that stress is everywhere. So in terms of pain management can be quite daunting if you don't know what to expect and you have the severe pain. But once you tell the patient what to expect, it really makes a huge difference to them. Next video. So the checklist also for pre-anesthetic clinic, treatment goals of pain medication regimen, run them through it for the first 24 hours, what to expect, and the next subsequent date. Name of the pain medication to be initiated after surgery, indication, dosage, frequency of each medication, and if the medication needs to be self-adjusted. Self-adjustment of pain medication by regimen. So usually this will be your patient control analgesia, whereby you just press onto the machine whenever you are in pain, and then they'll come and assess to see how much is your usage, and they will convert you to a different drug if necessary. The precautions and contraindications to emphasize again the importance of around-the-clock medication and when necessary dosage administration. So this is case-to-case basis for post-op patients or post-op cancer patients. So it's different. Action to be taken for a missed dose or when pain is not well controlled. Next slide, please. Pain NTM in the acute pain service or multidisciplinary team now. Next slide, please. So this is related to the patient who come out of surgery after that or any sort of pain, uncontrolled pain that's been referred to the APS team. So it's provided to patients who will be reviewed by the APS team and the multidisciplinary team around on working days. There should be at least one pharmacist, preferably the pain pharmacist. Next, please. So you have your list of patients that you're going to see, you prepare it, and then you follow what down, you take a medication history, case clocking, you identify any PCS needed and medication counseling appropriately. So some of the things that we do during the acute pain services now is to calculate the 24-hour requirement the patient has used from the patient control anesthesia. So if the patient prests like 10 times in a day, then you calculate how much was used up. If the patient has a baseline medication going on as well, then how much is the total requirement? How do you convert it back to an oral opioid? Or if the patient really needs something other than opioid, maybe there's something for multidisciplinary clinic, like an NSAID. So these are the things that we can discuss and suggest during the APS. Multidisciplinary pain team now, like for me in Wichita, we do multidisciplinary pain team now, where I do the pain with the palliative physician and the physiotherapist. We see our palliative patients and then we talk about their pain management. So that's our multidisciplinary pain team now. In other hospitals, we have the pain specialists, the pharmacists, physiotherapists, and so on. They meet once a week and they talk about difficult cases that they've encountered in a year, and they talk about treatment plans, so on and so forth. So every setting has their own different sort of multidisciplinary team now, but the most important thing is the involvement of the various health professionals in pain management. Next slide, please. So medication counseling, which is a general service provider, P&M. Moving on to the next slide, please. Okay, so this service is applicable both for the ambulatory and inpatient setting in a hospital or healthcare clinic that has pain at vital sign of their facility and is unable to provide the specialized pain and PN services. So for documentation and workflow, we follow your usual counseling about Ubatan 2014, which is available at the Pharmaceutical Services Commission website. Next, please. Okay, so as a general guide for patients that require counseling, again going back to this, the general counseling centers where they don't have a pain in the end. So you select your patients on complex energy regimen. So patients who have neuropathic pain and neuropathic pain, combination analgesic regime. For patients on long-term analgesia, we have special populations such as pediatric populations or geriatric populations, patients with multiple comorbidities, or patients with poor understanding, or patients who are referred by other healthcare facilities.
Madam Shavina, we have another 10 minutes to go.
Okay, yeah, sure. Next slide, please. Okay, so addiction, tolerance, and dependence. As I mentioned earlier, opioid phobia, this is a real problem, not just for clinicians, but also for patients. They are afraid to side effects because of the worry of the side effects, and they are worried about addiction and also not understanding what is it for. So this is common for doctors and for the patients. Both are the same. So physical dependence is a state of adaptation that is manifested by a drug classic specific withdrawal symptoms that is caused by abrupt cessation, rapid dose reduction, and administration of antagonist. So the patient will display withdrawal symptoms such as sensitivity, chill, nausea, abdominal discomfort, and running nose. Tolerance, however, is the adaptation in which exposure to a drug induces changes that result in diminution of one or more of the drug's effect over time. So basically what this means is that if you have been on this drug, for example, you're morphine for 3 months now, and the pain relief that you had after the first month now has a much reduced over time. So tolerance is something that is expected to happen if the patient is on chronic painkillers. So the only thing you need to basically is to increase the dose of the patient, because tolerance will happen, and it's something that we just need to be aware of, and it should not be misunderstood to being addicted to the drug. Addiction, however, is a adaptive pattern of substance abuse leading to clinically significant impairment or distress. It is psychological in nature and includes dysfunctional and compulsive pattern of use. So addiction basically is a psychological condition whereby the patient has a compulsive need to take the drug and to use it despite knowing its harm. It is to be differentiated from tolerance and dependence. So this is often the area where people get very confused. And so, especially for my palliative patients, I'm going to start them on morphine, mafan, and Mandarin will say mafan. They think that it is the end of life. A misconception again, or end of life, it means that there's no more treatment after this. It means my life is going to end soon. So that's one misconception. The other thing is, once I start, I don't be addicted lah. Tak apa. Doktor, saya boleh tahan. Dia to say, I boleh tahan sakit dia. Tahan, tak boleh tahan, baru I akan beritahu doktor. But why you need to tahan? Actually, we don't. What is misunderstood is you don't have to tahan. You should be pain-free. You need to be comfortable. Why I always tell my palliative patients, especially my patients with chronic pain, maki tak payah tahan. Yang penting sakit kena selesa. Itu yang penting. When you are in comfort, then only you can be happy, and then you can receive the necessary treatment for your cancer. If you are in pain, you are in discomfort, you are in distress, everything is affected. Your pressure is affected, the whole vicious cycle that is affected, longer hospital stay. So there's a lot of benefit when the pain is reduced. So this is why we need to know the differences between physical dependence, tolerance, and addiction. And so how do we do this? Next slide, please. We have something called the opioid risk tool. This is a scoring system, and it's different for female and male. So first we look at this should be taken at the beginning of starting a patient on opioid, and also subsequently in between periodically when needed, or if you suspect some addiction issues. So first contact is the family history of substance abuse, personal history of substance abuse, and age, history of pre-adolescent sexual abuse, and psychological distress. So again, just like pain score, if you have if you have score of 3 and below, you are at mild risk. So 4 and above, you are at moderate, and 7 and above, you are at high risk. So the moderate and the high risk patient needs to be assessed and monitored periodically. And that's how we use this as a general internationally used tool to identify patients who are at risk of addiction. Next, please. Okay, so the pharmacy pain management guidelines that we've published by the Pharmaceutical Services Program. Next, please. So we first edited the one in 2016, and we have the second edition in 2018. It's published by Pharmaceutical Services Division and is accessible at this website. Next, please. So this is what it looks like. Additional to this, we also have the cancer pain CPG that's available for as a guide for patients who start pain medication therapy management. We have a guideline for lower back pain. We have a guideline for neuropathic pain, and we have a guideline for non-cancer chronic pain as well. Next, please. Training program for pain pharmacists under the Pharmaceutical Services Program. Next, please. So we have a module for it, and currently you can get your training at JB, Hospital Sultan Ismail, or at IPO. It's a 2-week attachment, and there's a teaching material associated. But now we're trying to modify this attachment with COVID and ongoing COVID and all. We're trying to make it 1 week that you need to be there, and 1 week as a virtually present cases to your doctor. Next week. That's all. Thank you.